I have the pleasure of introducing Dr. Levy. Dr. Levy received her medical degree from Northwestern University. She completed a residency in internal medicine, followed by a fellowship in endocrinology at Bedside Medical Center at Harvard Medical School. Since joining the Mount Sinai system, Dr. Levy has become an associate professor of medicine and endocrinology, diabetes and bone disease, and director of the Mount Sinai Diabetes Center and Type 1 Diabetes Clinical Research. As the director of the Artificial Pancreas Research Program here at Mount Sinai, she has become a pioneer in clinical research, studying artificial pancreas as a novel way to improve the health of patients with type 1 diabetes. Please join me in welcoming Dr. Levy.
Thanks for the very kind introduction. So we're going to get started, and I realize this is sort of a transitional time of year, so I applaud everyone who is attending. I know that we've got new house staff starting in the next couple of days, if they're not already here, and we'll hope that there are no diabetes-related challenges. So first to start, housekeeping. I have no disclosures related to today's talk to acknowledge. So first and foremost, for anyone in the audience who is not an endocrinologist, I guess the big questions that come up in my mind is, why should I even be interested in this talk? I rarely see patients with type 1 diabetes. So what I want to point out to everyone here is that almost all providers actually see patients with diabetes, whether it's type 1 or type 2, even if it's only on a consultative basis. And likely within about 5 years, these systems may also be an option for patients with type 2 diabetes, so it's important that we all know about them. And then basically, anyone who has interest in technology is going to appreciate the process of this system's development as well as the future implications. And just to take a minor step aside here for the people in the audience who are more junior, I'm going to give you a little background on my trajectory. So I was a practicing clinical endocrinologist for about 15 to 18 years. Always wanting to do clinical research, really just wasn't in the right trajectory, didn't have the right mentors, and somehow about 6 or 7 years ago, the timing was right. So you can change your career pathway at any point if you have the motivation and the desire and really a trajectory with which to do it. And I share that with everyone just to keep that in your mind. That don't think anything's impossible. It's all doable if you just have the right motivation and team to support you. So what's my outline here? We're going to be speaking a little bit about background, some of the challenges that have occurred in terms of developing these types of systems, the systems that are currently being utilized, what we've done here at Mount Sinai, and some of the future directions that I anticipate and are actually already in process. So let's start with the patient perspective, because I think it's very important. So I'm an adult endocrinologist, don't typically take care of kids, but when a patient will present to me at age 21, having been diagnosed with type 1 diabetes at approximately the age of 5, what has this patient already done? This patient's probably already calculated the content of meals 24,000 times, meaning looking at what they're eating and figuring out how much insulin to take. They've tested their blood sugar most likely 29,000 times. They've injected insulin probably about 35,000 times. This is just by the age of 21. And then they're coming to see me. And they've got at least, if we're lucky, another 20, 30, 40, maybe even 50 or 60 years that they're going to be potentially continuing to do this. That's a lot of burden for a patient. And the question becomes, is there a way to alleviate this burden? Let's take a step back and talk about where we are even. So that patient is doing all this stuff, but how good are we really doing in diabetes management? So let's take a look at the T1D Exchange Clinic Registry. So what is the T1D Exchange Clinic Registry? It's a survey that's sponsored by the Helmsley Foundation looking at sort of the premier diabetes-based practices in the United States. And Mount Sinai was invited to be part of this a few years ago, yay. And what has been evaluated is the initial starting sites over a 5-year interval of time looking at the care for patients with diabetes. In 2015, they did an update to evaluate the trajectory and progress of these patients. And what did we find? So this is target for adolescents, which is 7.5 in kids and under. And this is target for adults. So if you look here, it's pretty sad. Only 30% of type 1 diabetes are actually meeting glycemic targets for the ages of 26 to 49. And only about 29%, so about the same over the age of 50. So only a third approximately of the patients with type 1 diabetes are achieving glucose goal. For anyone who has an adolescent as a child or has been an adolescent, I think that's most of us, you can see it's even more abysmal. particularly in this age range. And you can only imagine the challenges. Why are there such challenges? Because of all the patient interaction and involvement. We talk all the time about non-compliance and non-adherence of patients. This is hard work. This is not easy for patients. Thus, this decision was discussed probably about 10 to 15 years ago by a lot of technology teams throughout the country and throughout the world. Is there a better way? Is there a way that we can better support patients in this endeavor in terms of managing glucose control? And this was when the concept of the more official closed-loop systems were established. So what is a closed-loop system or an artificial pancreas? And I'll show you all why I'm talking about closing the loop. What happens in these types of systems is that patients' glucose levels are integrated into an algorithm to help manage things. And I'll explain to everyone what these devices are, but what they consist of is an insulin pump, a glucose monitor, a glucose sensor is what they're really called, and a platform to host the algorithm. So what happens is the system officially checks glucose, there's insulin delivery calculations that the patient does not have to do, and then there's insulin delivery. So I'm calling this closing the loop just for this nice little cute reason here, which is because we're closing a loop of what happens. Glucose readings, this is a glucose sensor potentially, patient parameters, the algorithm, glucose prediction made by the algorithm, and then it tells basically this insulin pump how much to administer. So what's an insulin pump? Aside from the endocrinologists in the audience, how many actually has ever seen an insulin pump? Okay, so good number. How many people know someone with type 1 diabetes? All right, I do too. But so, I mean, it's important to realize that these are things that people are wearing on a daily basis. You're going to see them in the hospital. You're going to know these patients. So these are some of the insulin pumps that are available on the market. I have not included all of them. And basically, what is an insulin pump? It's basically a big syringe. That's all that it is. It delivers insulin. There are all kinds of settings and features that are programmed in, such as basal rates and parameters for giving insulin doses, but it's basically a big syringe. So it's not that scary. What's a glucose sensor? A glucose sensor reads glucose levels real time, meaning every 5 minutes. Patients wear these now, and I'll show you a picture of one in a couple seconds. And what it enables a patient to do is see what's happening with his or her glucose levels even when they're not checking finger sticks. So we recommend patients do finger sticks maybe 4 times a day. If we're lucky, they'll do them 6, 8. Pregnant women will do more. But this really enables a patient to see what's happening continuously. This is one of the 2 glucose sensors currently on the market. And I'll just give you a little bit of orientation. The patient has to insert this on a weekly basis. That looks a little ugly, but patients can usually manage it. Trocar, plunge it in, little needle that's under the skin that's actually the sensor. There's a transmitter, and then a receiver, or actually an iPhone or an iWatch, and these have recently also been available for Android phones. So this is what the patient sees. They'll see what's going on with their blood sugar. They'll see it's rising. They'll see it's dropping. And recently, these devices have become much more accurate, which has really improved the ability to create and progress these artificial pancreas systems. Why are these sensors so important? So this is a pictorial. It's not an actual patient. But what I wanted to show you is that, let's say patient A is checking their finger stick a few times per day. Look what's being missed. Hypoglycemia throughout the entire night. Other times with extreme glucose spikes that the patient has no way of knowing without having this adjunctive data. Medicaid just expressed interest in covering these for patients with Medicaid insurance. These have just been approved for Medicare patients as well. They're not yet available, but it's very exciting that we can offer this opportunity to many, many more patients with diabetes. Let's take a step back. Although these have really come into great interest in the last 5 or 10 years with the advent of more accurate glucose sensors, this is the history of this. So the first artificial pancreas systems were actually started by a physician, Arnold Kadish, back in 1964. Just to orient people, this was all intravenous. You had intravenous insulin going, intravenous glucagon going, and a methodology with which to test the blood sugar every 5 minutes. He was quite ahead of his time, but clearly this was not something that someone could do on a routine basis. Then came the biostators in the 1970s. A few of us, including myself, remember these. This was more of a research tool. You can see the size of it. And this was an insulin-only system managing glucose levels. Not really portable. So what happened about 6 years ago is that with the advent of improved glucose sensors, we were able to proceed in terms of development of these systems, and these were laptop-based systems at that point. These are some of the older yet better glucose sensors that were utilized back in about 6 years ago, and some of our insulin pumps. And what would basically happen is that data from this would feed to this, would go to that. Once again, better than the biostatter, but still not particularly portable. This is when the real change came, and this is the team at UVA that we've had great opportunity to collaborate with. This is Bedside Ap Technology, and let me orient you as to what this is. Remember that big computer I showed you in the last screen? Now here's what we've got. We've got a smartphone. Okay, you're not receiving phone calls on it yet. That might be the future of this, but at the current time, this is basically a mini computer that a patient can carry around. Feeds back and forth to a glucose sensor, insulin pump, and basically you can see there's a whole bunch of features that a patient can interact with, entering in a meal bolus, and I'll explain to why that is still needed. Can enter in if they're treating a low blood sugar, can enter in if they're doing a finger stick. There's still quite a bit of patient interaction, but what this system does is if someone's sloppy or doesn't dose appropriately, which is very challenging for patients with diabetes, this system will pick up the slack and basically improve their glucose control, especially overnight. So that was a couple years ago. Where are we now? So the first closed-loop system has actually been FDA approved. This is Medtronic. Some people may know Medtronic if you're a cardiologist from the pacemaker side. Medtronic purchased MiniMed in about 15 years ago, and they helped to develop this technology. So this is unbelievably exciting, glucose sensor, and these are available now. So you could see someone in the hospital wearing one of these. Insulin pump. Doesn't give quite as much data as the one I last showed you, but the patient can see what's happening here. And there's a controller algorithm that's available. Is this fully rolled out? Not yet. Mount Sinai, we were very fortunate to be the priority access site for New York City and have about 10 patients actively on these systems, but there are going to be more. What I do want to tell you is that this is the first. It's sort of like that first phone, for those of you who remember, that you carried on your shoulder, or your much bigger ones. I see someone smiling. I remember that phone too. But basically, these are the first, and they're not going to be the last. These are the preliminary systems. They're a little wonky. They're pretty good. For patients who really need them, they provide a huge benefit already. What else is coming? So this is one that we're in research about. This is Type 0 Technologies. Remember I showed you that pump sensor and before that other phone. This is a commercial grade version of this that the team at UVA separated and started their own company. And I'll give you a little more data on this, but it gives patients a little more data. In some ways it's more private, is one more device to carry, but it gives them an opportunity to really manage their control. And once again, hopefully the phone piece of this will be added to this quite soon. iLet. So the team at Mass General is great with names. So for any of you who think about diabetes, it's the islets of Langerhans, so they named their product iLet. They're amazing in terms of what they can come up with marketing. And this system is quite unique in that it delivers insulin through one port and glucagon through another port. Not yet ready for use. Glucagon is not a stable hormone. For anyone who's ever had to administer glucagon, you've got to mix it immediately, inject it, and then it's not good within 24 hours. So this is not yet ready for prime time. I would say 2 to 5 years away, probably closer to 5. The trajectory always gets pushed off, even though we get excited. But it's an interesting concept, and this one too has a phone to operate it. So patients got frustrated with this and said, we're not waiting. Why does it take so long? And I'm going to get into that in a little bit. But patients in the past 3 to 5 years became very frustrated with having to wait for these systems to be developed, released, and improved. So what occurred was a group of very high-techy patients with type 1 diabetes or with children with type 1 diabetes developed a system called openaps.org. We are not waiting. So what happened is these patients basically hacked in, and I'll show you a prototype of this, of some of the older insulin pumps to develop a closed-loop algorithm to help manage overnight settings. This is an OpenAPS system. Okay. I actually have a couple patients on them. Patients email me all the time asking about them. There are certain risks of this that you can clearly imagine in that in an operator who is not particularly adept at troubleshooting, may have wrong insulin pump settings established. This can be very problematic. But so this is a glucose sensor once again. This is sort of a mini computer. This is a charger. This is one of the earlier versions of insulin pumps, and I'll explain to you why in a second. And then this is an adapter or an interpreter. So the patient has to carry all this stuff around. For some patients, it's worth it. There's been posters presented already on this data, and I would say probably about 80 to 100 patients that we know of in the country are utilizing these now. I just got an email this morning from a mom of an 18-year-old I take care of who's going to college. Hey, can we start him on this? I'm like, but just to be aware. So what are some of the things you need to note about these is that you can only use older insulin pumps to utilize this because the newer pumps are much more cybersecurity prepared and cannot be hacked. So there's all kinds of sales and communications on eBay about how to get these things. And you'll see once of these in a blue moon, but you have to utilize these with extreme caution. Anyone who does not have technical expertise, this is basically, can be extremely dangerous. Okay. This is not a great quality slide, but just to talk about the other direction that this can go. So what is Bigfoot? Bigfoot is actually a hacked artificial pancreas system from a patient of mine and her husband and their son that is now going into commercial research in California. So patient of mine who was actually a Harvard medical student when I was doing research as a fellow, came in to do studies with me, found me in New York after she moved here, and I managed her through 2 pregnancies. Unfortunately, she had a child who developed type 1 diabetes. And her husband, who always noticed that for his wife it was very easy to manage, it was a disaster to manage their son. Blood sugars are going like this. You can only imagine with a 5-year-old what was happening. And he said, I'm a quant on Wall Street. Maybe I can figure out a way to do something with this. He actually hacked into insulin pumps, hacked into glucose sensors, and created a system. People all were reaching out to him. They said, hey, can you give us your algorithm? Can we utilize it? And he said, no, I don't feel safe about this. I'd like to do this in the right way. And this is Bigfoot, which is now in early phase clinical trials at this point. And really an impressive team. Everyone who works there actually has type 1 diabetes or a spouse or a child with type 1. So let's get back to why are these systems only just now becoming available? First, I already mentioned to you about 3 times device improvement. Other factors that are involved. These are laborious processes. What do you need to do to get one of these approved? First, you need to get approved investigational device exemptions. Then you need to do inpatient GCRC studies. Many patients in the inpatient GCRC. Let's say there's a problem with the algorithm, then you got to go back and fix it. Then you got to do more inpatient GCRC studies. Finally, you think you've got it tweaked very well. Then you got to go to supervised outpatient hotel studies, which we've done here. Those are not for the faint-hearted. 24/7 in a hotel, supervising patients, physician on site. Yes, I've done these studies. Yes, many of our endocrine fellows have as well. Then you send them home for brief home studies, 5 to 7 days, to make sure the systems are safe. And then you start the pivotal studies, which are the ones that go for FDA approval. Medtronic, which is clearly a much larger company, had likely more resources, and that's why an industry-based company is starting with this process and having an approved device. So what are some of the challenges? I mentioned some of them already. There's some delays in insulin absorption. That's a big challenge. Onset of insulin action for what we call our rapid-acting analogs is about 15 to 20 minutes. That's why we always plead on the inpatient setting the nurses administer the insulin before the meal, not after the meal. In addition, these glucose sensors have about a 15 to 20 minute delay. How do we address all of this? Okay. And there's also challenges with connectivity. I forgot to mention that. But the onset of action of insulin can be modeled into the algorithm to a degree, but that's why the patients still have to press a button and let them know when they're eating at this point. Some of our challenges with glucose sensors is the lag that I already mentioned, but there are algorithmic solutions, which I'm not going to get into detail about, that can help to fix this. The systems can basically integrate that they know there's a lag. So let's talk briefly about the results from academia, and I'm going to keep track of time. I'm not going to go through too many of these, but you'll see that most of these studies that were really important, they were all published in the New England Journal of Medicine, so they're relatively important studies and things to keep in mind. This is the first outpatient study that occurred, studying kids at a camp with type 1 diabetes. This was an Israeli team. You'll notice the first studies that really got out in the outpatient setting were in Europe. The FDA has slightly more stringent guidelines for better and for worse. I don't argue with it, but just to keep in mind. So this was 56 kids with type 1 diabetes, 2 nights wearing a closed-loop system in a camp. Kids in camp go crazy, for anyone who can imagine. Difference in glucose levels, this is a clinically very significant difference with a lot less hypoglycemia. This was a supervised setting in that there was a whole bunch of people in a camp bunk watching these kids. So this was outpatient, but the first one really done in an outpatient setting. Then there was overnight at home studies where patients went completely home unmonitored. This is the team in England, Roman Vorka. They've actually even done some work in pregnancy already with these systems, which is pretty amazing. Closed loop overnight versus sensor augmented pump, which means basically a sensor and a pump. Unsupervised, nobody was watching them. Overnight systems. Why overnight again? Because overnight works better because you don't have to worry about covering the meals and the onset of action of insulin. Time and target, 64% versus 47%. Doesn't sound overly impressive, but trust me, for someone with type 1 diabetes, this is very impressive. And here's some of the data, and what you can see here, I'll just show you, control arm, closed loop arm, once again, control and closed loop. Bionic pancreas, once again, Mass General, islet, bionic pancreas, they got great names here. This is a dual hormonal system. This is some of the earlier academic development of it. You'll see that there's insulin and glucagon going in 2 different insulin pumps. So a lot of device burden for a patient. Control system, once again, on a smartphone, and the glucose sensor. Interestingly, Brian Maslish, whom I mentioned earlier for Bigfoot, he actually created these sleeves and shared them with all the academic institutions. So what did we find in this study? Day 1 was kind of a wash, but days 2 to 5 of this type of a system improved glucose control via sensor evaluation from 159 to 133. The time in range improved significantly, almost as high as 80%. Hypoglycemia was reduced, although still fairly significant in this population. And the overnight mean glucose level was even more improved. Pretty impressive. Once again, these are going to take longer. How do these systems work? It's like going into the shower, high hot, high cold, running both of them at the same time. So theoretically, there are some concerns about if one of those gets blocked, what's going to happen. I will share with you that the Mass General team also has a lot of insulin-only studies, which look almost as promising. Other outpatient studies, this is the team we're collaborating with at UVA, Stacy Anderson and group, looking at first US study in outpatient closed loop systems, SAP 2 weeks at home with sensor and pump, 2 weeks closed loop control. And this slide's a little hard to read, but I'll just orient you. Basically what you're seeing is as time and range improves in overnight as well as day. Mean glucose went down. Didn't go down much during the day because of, once again, the challenges with eating meals, but you do see improvements. And significant improvements in reduction in hypoglycemia range, both day and night. Okay, so what have we done here? So this was the first study we did, and this was no small feat. Andy Stewart's in the audience and remembers how we managed to pull this off at the beginning, and thank you, Andy, and thank you to Susan Mirsky, who believed in us to help us get going. But this is the first study we did here at Sinai, and I will tell you that I was scared to death when we started this. So this is a study of the artificial pancreas system in collaboration with UVA, 3 study sites for the initial study, which was UVA, Mount Sinai, and Mayo Clinic. Later on, a team in Padua joined us. This was our first study subject. For anyone who reads the New York Times and sees those artificial pancreas ads, this is her. This was our study protocol. So basically, just to give people, you remember, these are hotel studies. We're all going to the hotel. We're all hanging out in the hotel for 5 days. And basically what it was is 5 nights of artificial pancreas versus usual care. This is where we did the studies. So just to give also a shout out to our IRB, I don't know if anyone is in the audience from the IRB, the fact that our IRB had the faith in us after presenting all the data to let us start these studies, for this never having been done at this institution, is a pretty big deal as well. Other institutions, no problem, but this was a big deal. So we did the study here, okay? There were a few more rooms. We weren't all sitting in the suite, but literally people were up overnight, sitting at this table, watching computers the entire night. This was our study cohort. The point I want to make here is take a look at this A1C. This is some of the challenges and positives with these systems, is that everyone's really well controlled overall. We got to get these moved out to patients who are not as in great glucose control. This is just to remind you what we were studying. You already saw that. And this is what we looked at on a screen overnight. I literally stayed up for 5 nights watching these screens. I might have gotten 2 hours of sleep. But just to orient you what we were watching, this was insulin delivery. This was actual blood sugar level. And if there's a prediction of potential hypo, a yellow light would go on. Insulin delivery was reduced to try and prevent that, and sure enough, it actually did, and I was biting my nails a lot during this study. These are some of the results. Once again, I'm going to rush through this because I think you can see it fairly well. Improvement in glucose results overnight, as well as 24/7. So this was only an overnight study, but what we found was even just improving overnight blood sugar levels, patient wakes up with a good number, their day goes well. Once again, showing this data, and we also had this secondary outcome of time in range overnight. And once again, pretty impressive, almost 90% versus standard of care. This is some of the other secondary outcomes, and this was just accepted for publication in JCE&M. So this data is currently available, but the conclusions obviously showed that there was increased time in range, there was reduced hypoglycemia, there was a patient consistently coming in at 120 in the morning, which is a big deal if you think about your inpatients or your outpatients with type 1 diabetes or even type 2, and you saw a similar trend at home. So that's all great, but as I mentioned, still a lot of patient input, still a lot of work for the patient. They got to enter in what they're eating, they got to enter in what they're doing, they got to remember to do that. We're getting back to those adolescents and not so well-controlled patients now. Do they even remember to enter in meal bowls? Does anyone ever take care of a patient? I forgot to take my shot. Happens a lot, can't fault them. People have busy lives. If any of you who don't have diabetes ever tried to take care of yourself during residency, just imagine remembering to take all your shots, checking your blood sugar, doing all this. It's not an easy task, and for anyone with diabetes, this is a challenge. So this is a system which we collaborated with RPI. They have a really great team up there who've been working for about 10 to 15 years on artificial pancreas systems. No clinicians there, though. And this is a study that we were invited to participate in with 15 subjects at 3 sites, Stanford, Barbara Davis Center, and Mount Sinai. 13 females, 2 males. I won't comment on that, but more women seem to be interested in being participants. Mean age 30 years, average duration of diabetes 18 years, and once again, that really good A1C. And I'm going to show you data later with higher A1Cs. So what was the coolness about this system? Was patients didn't have to input anything. Not even exercise. They didn't have to tell the system they were exercising. And what do we see here? Is you see there was an activity monitor that the patient had to have taped on and wear, sensor, insulin pump, and this algorithm. So what did we see? This is a little hard for people to really fully appreciate, but I'll explain to you what it showed. 73% of time in range, 83% of time overnight, and minimal hypoglycemia. So that looks pretty great. So why do we have to do meal announcements? I'll tell you a few secrets about this study. Whenever we saw an arrow going down, we kind of had them eat in advance. So we may have falsified the frequency of hypoglycemia had a patient been at home. We actually let these patients walk around. We were tracking them on iPhones. Hey, you're only allowed to go down to 86th Street. Wait, you're at 85th, you got to come back. We were literally tracking these patients 24/7 from the hotel. But there were some concerns about the frequency of risk of hypoglycemia, so a follow-up study was completed. And for this one, we chose to study higher A1C patients. 10 subjects were studied, 3 sites, with sort of a less aggressive system. The accelerometer didn't work so well, so that was removed, and they still would then have to announce exercise, but everything else was still permitted to just let the system take care of it. So the data showed slightly higher data, but still pretty darn good in terms of what you see for results here. So glucose full day, overnight, pretty impressive. Time under 50, quite low. Time under 70, a little bit higher. One of these was actually a false sensor reading. I know that because it was a Sinai patient. Significantly improved time in range, as well as really not very much severe hyperglycemia. I never thought the system would work, and I applaud the team at RPI for actually coming up with such a really cool algorithm that nobody believed could be done at this point with the insulins we have available. This is to show you what happens, though, with a meal announcement versus no meal announcement with this system. So we really maximally stress these patients. We had them eat a breakfast of cereal, a glass of juice, and skim milk. That would raise anyone's blood sugar with type 1 diabetes through the roof. And basically what you see is, yeah, if they don't announce the meal, they go pretty high. But still better than someone who never remembers to dose for a meal in advance. This is what they do if they're actually taking an announcement. So that was that data. That has not been formally finally presented, so it's not published. I can't share any more details of that, but there's going to be some follow-up studies, but it's already been submitted for publication to Diabetes and Technology, and we're very excited because I think that's the wave of the future, is less patient input. So where are we at now at SANI, and what are we currently doing? We were invited with several sites for an NIH-sponsored study called the IDCL. And I remember the happy dance that I know I did when we were invited to join and this grant got funded. This is looking at an artificial pancreas system at multiple sites throughout the world. Subjects are studied for 3 to 6 months on this system, and it's the largest NIH-sponsored study, and it's probably one of the only ones that's actually active at the current time. We're looking for patients ages 14 to 70, looking for both high and low A1C patients. So if anyone has patients in the clinic you think might be appropriate, that would be great. They already do need to be on an insulin pump. There's going to be a 1-to-1 randomization to ensure that insurer payers down the road will be willing to cover these systems. You have to show benefit. So we've already studied 4 subjects in this study. This was phase 1, where we were using 2 insulin pumps and different glucose sensor. Then there was a second phase with 1 additional follow-up subject. There were some challenges, as you can imagine. That's why you do a first study before you roll it out to the masses. Some challenges with connectivity. Those have been corrected, and the main study will be happening probably towards the end of this summer. This was our study protocol. Basically, they would wear it. Why is this called a training study? It was also training us to make sure that we know how to operate and manage these patients. What did we see? This is what the patients saw. Patients would see what was happening with their blood sugar. They would see what their sensor was doing. They would see how much insulin was being delivered. And then down here, they could enter in data as needed. This is what we monitored. Were we monitoring 24/7? No, we would check in with them once a day and kind of take a look and see how they're doing. Now, someone smart is going to say, wait, there are only 4 patients in this study. Why do you have all these extra ones? We were not wearing these systems with insulin in them, but the entire study team wore them so that we became comfortable with them. Obviously, appropriately clean them before we transfer them out, but I wasn't going to put anything on a patient if I didn't know how it worked. What's next at Sinai? Several different studies are up and coming, and we're actually going really well with time. I talk quickly, so there'll be time for questions. What's the wisdom study? So for anyone who thinks about that title, it sounds like maybe it's something to do with older people, wisdom, age. So we're actually part of a study looking at the use of glucose sensors and the benefit in patients ages 60 and older. I think this is a really important study to show the true benefit of these systems. A decision support system for patients on multiple daily injections. Not everyone with type 1 diabetes wants to wear an insulin pump or wear all of this hardware. This is another way to do this with a smartphone algorithm based on artificial pancreas programming. That's going to be rolling out at the beginning of this summer, mid-summer. Follow-up studies with less patient input, the RPI collaboration. They're actually the only team in the United States that has a level of system that's actually doing this at this point. Use of more rapid-acting insulin. Study was just published in Diabetes Care a couple days ago called Onset 1. Faster-acting insulin analogs, faster than what we have. We were fortunate enough to be a site for that as well. Very exciting opportunity for patients. These insulins work quicker, which is really what we need to make these systems more effective. Pregnancy. For anyone who's ever managed a patient with type 1 diabetes during pregnancy, this is the hardest time for a patient. Glucose targets 90 to 130, always grave risk to the baby. This is an area that's still ripe for development. Only 1 team has actually studied this. My dream is to get a system here going at SANI in that area. And then additional developments are how do we reduce patient burden and what do we do for training? We have a National Science Foundation grant submitted already to really how to roll out appropriately the appropriate training for these. I will share with you it was a learning experience for me when we rolled out that Medtronic system here. We really had very little training and really had a lot to learn. And I think the more education out there for healthcare providers as well, because these may come to the PCP practice, is very important. What are the future directions? So for many of you sitting in the audience, you're saying, wow, this would be great in inpatient. This would be great in type 2 diabetes. One of my colleagues, Ron Taylor, was always saying, why don't you put these on the inpatient setting? So there's been one study that's actually been done about inpatient in terms of artificial pancreas in type 1s, and it looked fairly promising, but you have to think about the device burden, the nursing burden, et cetera. So these are going to come, but it's going to take some time, and we also have to weigh the cost-benefit analysis of that. Type 2 diabetes studies have already been started in type 2 diabetes for patients who are utilizing insulin that really are not achieving glucose control. There's some different needs and risks and benefits associated with that population, but it's a very important area. I already mentioned pregnancy, and then of course, as I already mentioned, the system improvements are going to keep coming. These systems are the beginning. They're going to continue to improve, and they're going to continue to get better and better, and we're going to look back at these initial ones in a few years and say, that was all they were doing, but these systems are going to keep getting better and better. So, in summary, what have I discussed today? Artificial pancreas systems, number one, reduce hypoglycemic episodes. I hope I've convinced you all of that. They improve time and target range for glucose levels. They have multiple modes of use for patients, sometimes just overnight. Sometimes they can be day and night. And there are components that can be adapted for broader contexts, such as daily injections, finger stick testing, etc. And I've also reviewed some current and future directions. Okay. This is always that thank you slide. And this thank you slide, there are a few people missing. Grenier, who's in the audience, is one of our endocrine fellows who's going to be joining us in a couple days. We're very excited to have you start, Grenier. This is the Mount Sinai Artificial Pancreas team, missing a couple of people, but gives you the perspective. And once again, these are people who are 24/7, doesn't matter. Selassie Ogiata was a technician who worked with us watching a screen overnight for a few studies, is now our research coordinator. I want to give a shout out to Dr. Dunaif, Dr. Stewart, and Yaron Tomer, our former chief of our division, who really believed in me and helped to get all of this going. The team at University of Virginia, the team at RPI, the team at Stanford, the team at University of Colorado, Mayo Clinic, NIH, JDRF, Helmsley Foundation, and all the donors, including Susan Mirsky, who is too shy to admit it, but she was one of the true believers in representation of her husband Stan in getting all of this started. And the biggest shout out, of course, goes to the study subjects and all the patients who had the patience to be part of the studies and learn these systems and tolerate some of the challenges we went through them with all of us. I thank you for your time. Questions, if any? I know I talk fast and give a lot out there. Yeah, Andy.
Yeah, so I just want to say for the audience first that Carol really has done an incredible job. Sinai is the first and only medical system in New York, hospital system that has artificial pancreas. It's entirely due to Carol's energy and drive and commitment. So just congratulations to her. So say I'm a type 1 and I want this. What do I have to do? Am I eligible, and how many people? I mean, my calculations were 65,000 type 1 diabetics in the metropolitan area. So how many have you done? How many can you do? And what would I have to do if I wanted to be part of this?
Right. So those are all actually really great questions. So the first one I'll start with is actually, there is a system currently that has just been approved. And what I'll share with you from our personal perspective is there have been some insurance hurdles to getting these covered for patients. Some insurers are declining them at this point, saying we don't have burden of proof yet. There's obviously discussion of that in process. And then patients have to be due for an upgrade. So if you're not due for an upgrade, yes, you can buy one of these out of pocket, but they are not yet available to everyone. To be eligible for one of the research studies, at least for the ones we're currently doing, we do believe that training utilizing an insulin pump is necessary before going on one of these systems. Other groups are starting to consider, well, just going from daily injections right to a closed loop system. Right now, patients need to be on an insulin pump. That is pretty much one of the only major criteria. Is they cannot be pregnant. But those are really the big ones at this point. We've really tried to limit these studies in terms of exclusionary criteria to make these open to the masses. The challenge is getting these patients with higher A1Cs in, because those are the ones who will derive the most benefit from these systems, and really getting them to reach out. And what we've done is we've basically reached across the healthcare system, clinicaltrials.gov. There's many different ways to advertise these. I'll be very frank, patients are breaking down the door to do these studies. We haven't had any trouble recruiting, but we're always excited to have new patients enrolled. So it's about the same 10 or 15 that want to do them.
And is there a limit to the number of patients you can enroll here?
So for our studies, yes. So we do have a limit at this point. I mean, sure, we can do more, but we don't necessarily have the support staff to manage more than that. Currently, we are allotted to do 20 to 24 for this NIH study. More studies are coming. Other pump companies have already expressed commitment for us to do further studies down the road. There's a few percolating right now. I predict we will have 3 to 5 studies going if everything works out appropriately within the next year. So there'll be definitely more than just one study opportunity for patients. Mike?
I have to ask a question for a couple geriatricians in the room,
Yes.
and some of us who are of that age. Is there some reason why you have an upper limit on the age of the participants? Do the participants have to have their own input, cooperation? What's the problem?
Yeah, so the patients do need to be able to operate the system, and you could clearly make the argument to me that someone of the age of 72, 74, 75, 60 is the new 40, as we all know. But it's, there was a cutoff that had to be created for safety. But at the current time, these systems do not do everything for the patient. Patients have to change the catheter. There is some patient involvement. That is the purpose as well of the Wisdom study, which I mentioned, to really see the efficacy and utility of these systems and there's no upper limit for that study, but that's looking just at glucose sensors. I agree with you that for older subjects, we actually submitted a grant for the older subjects with type 1 diabetes. It was not funded, but I agree with you that we need to be able to have the opportunity to roll it out. Also, I will state to you that closed-loop systems are not yet approved by Medicare. So that's an additional challenge.
The last time I looked at tight control and type 2 diabetes, I came up against Advanced, Accord, the VA study that showed that tight control either did nothing or was actually harmful to the people in those studies.
Yes.
So my question is,
Yeah.
the DCCT study
Yeah.
is always quoted as showing that in type 1 diabetes, it actually prevents either micro or macro complications.
Right.
Are there any other studies that show that tight control in type 1 diabetes does good?
Yeah, yes. So there's actually quite a few of those studies. There's one from Pittsburgh, as I remember, looking at retinopathy. It's unequivocally proven repeatedly that type glucose control and type 1 diabetes, multiple studies, nephropathy, neuropathy, you name it. And also that was one of the largest studies ever done, but there are other supportive studies that clearly confirm that. But I want to take issue with what you stated about the cord and all of those other studies as well. These are longer duration patients that the belief at this point is get them when they're young or get them before they already have complications. For patients who already have cardiovascular disease, yeah, you may not want to rapidly, aggressively improve glucose control with the theoretical risk of hypoglycemia, which has been raised. And Dan Donovan, who's one of our investigators for Accord, is actually in the audience and may have further commentary on this. But I don't think that we can say that there's no reason to control blood sugars in type 2 diabetes. I think that what we need to say is we need to be selective about which patients we want to achieve tighter glucose control. But if I have a 48 or a 50-year-old patient who was recently diagnosed with type 2 diabetes, I'm not going to say, okay, we're just going for 8 because there's no purpose to controlling your blood sugars better. I don't think that that's been fully validated.
So another question. You said early on that the newer systems are not hackable. I think that you underestimate the abilities of the younger people here.
Yep.
In terms of hacking, and have there been any instances where either because the patient is manipulating things wrong or because somebody actually got into the system where bad things could have happened?
So nothing on the newer models. So the last model of insulin pumps that was quote hackable was the Animas Ping. That's the last one. And there actually were cybersecurity experts with type 1 diabetes who actually proved that they could hack into it. Has anyone ever, you see all this on pacemakers and TV and all kinds of movies about people hacking into these devices. The level of Bluetooth security on these newest systems, at least as of now, really make them, and there's a whole cybersecurity team for artificial pancreas that actually now validates the safety of these insulin pumps. It's a totally appropriate and valid question. But currently, the way these systems are set up, it does not appear that they are hackable. Now, then you can get into this whole discussion, well, yeah, but if somebody really wants to kill someone, somebody comes up with this way, you've seen all these things that come up. You would also need to be within 20 feet. There was some medical resident who I actually think is going to be training at Sinai this year, I don't know if he's in the audience, who said, we were out at the restaurant, and one of my friends all of a sudden got a bolus from someone else across the room and had a hypoglycemic episode. None of this is actual reality at this point. Is it theoretical on some of the insulin pumps that are older models? Yes, but that's why people figured out how to do this. Is it theoretically possible it could happen in the future? Yeah, I guess theoretically it is, but think about it. It has to be somebody wants to do this to somebody else and goes through the entire cybersecurity process. The number of steps you have to go to get to that level, I think, is pretty intense. Tracy, yeah.
That was a great talk. My mind is kind of blown with the hacking potential. I'm fascinated by the open source potential there, right? We talk all the time about diabetes being a self-managed disease.
Yes.
And no one is more motivated to figure this out than either a technically savvy person with type 1 or the parent of someone with type 1.
You're absolutely correct.
And so my mind's like spinning because I'm thinking if you harness, if you truly create an open source creativity lab where you get the smartest folks around playing with systems, and I'm not saying testing clinically and people are going to take their own risks to do whatever, but how are industry partners potentially harnessing that innovation, because that's really the wave of the future, right? So this technology is no longer in the hands of just the company or the tech companies or academia. It's potentially explosive in terms of the accelerated time to invent something. So like you're a patient who's now doing the Bigfoot, that's getting silent or getting put in an academic oversight.
Well, it's put into an industry perspective. It's not academic. But so the challenge becomes is that the only utility of these open APS systems right now are, as one of the other people here raised, is that those pumps are very hackable and those are not available. So the question would be, would a tech company be willing to produce a pump that's hackable? Because of all the potential risks that could occur with that. There are other organizations, Tidepool is one there where we can retrieve glucose data and interpret it, that basically invite patients, and this is open to all of academia as well as industry. Hey, send us your data so that physicians can utilize it and come up with new sources of systems to manage diabetes. And those are already available, once again, founded by a dad of a kid with type 1 diabetes. But you're absolutely right. And when my first patient came in saying, hey, I'm on open APS loop, I kind of looked at her and I wasn't going to throw her out of the office, but I was like, I just have to warn you, you can't turn these patients away. That's my personal opinion, but you need to share with them at least the theoretical risks that are involved. But I agree with you 100%. Out in Silicon Valley, half the people are on these systems already. Chief.
That was a great presentation.
Thank you.
I had a friend who died in the middle of the night.
Yes.
And I think we underestimate the danger of nocturnal hypoglycemia. So I'm a little disappointed that the systems still allow that to happen.
So Terry, what you got to look at when it says about 1%, you need to think about overnight. So the time that's called overnight is 11 p.m. to 7 a.m. So maybe 1% of the time, the blood sugar is under 70. It doesn't mean, if you remember the data, it was less than 0.3% for one of the slides I showed you for under 50. This is extremely low and dramatically changes things for people with diabetes. Many patients with type 1 are low half the night and we just don't even know it. But I think that's as good as you're going to get, because also you have to understand that someone can take a huge bolus of insulin themselves and the system's not going to be able to prevent that hypoglycemia. I actually think this is a huge step. I appreciate your point and it's very appropriate, and that's why the overnights are so critical.
But do you separate out, because Tara's question is severe hypoglycemia? It's one thing if
Yeah,
you're 70 and you're 62, it's another thing if you're 38.
So we did 50. There was no severe hypoglycemia in any of these studies. Nothing with unconscious, zero severe hypoglycemia. No.
Are there any alarms on these systems?
Oh, yeah.
That wakes the patient?
No, they will alarm the patient quite loud if they're hypoglycemic. The glucose sensors even do that, but sometimes patients sleep through. But the difference with these systems is they shut off insulin delivery, or they reduce it and they anticipate hypoglycemia is coming. But there were no, thank you for raising that, Tracy, there were no severe hypoglycemic episodes in any of these studies.
Okay, let's thank Dr.